Okay, thank you. Thank you, João, for this very kind invitation, and thank you all for adapting to the time and the contingencies of attachment relationships, namely with my daughter, which I haven't seen in a few days, so my arousal is very high. I'm quite happy to be here. About almost 15 years ago, I started my own clinical training in a therapeutic community called Institut Maïeutique in Lausanne. I basically learned all that I know about psychosis by living with patients for 2 years, day in, day out, on the weekends, during the vacation, also following them in therapy, and it's been an amazing experience for me, from which I draw on. I do not practice in therapeutic communities anymore, but it reminds me coming here about the kind of quality work that one can do when one is dedicated to really impacting the environment and the surroundings of the patient. My own talk is going to be on mentalization and giving you some thoughts about how we're trying to adapt mentalization-based treatment to psychotic disorders, and my work is more specifically on emerging psychotic disorders, so the very early stages, often before the transition to a diagnosable disorder. But of course, this is not only my work. I work with a host of people in Geneva, in London. This is not very efficient, I can see. In Lausanne and in Boston. So I'm going to draw on some of the thinking that's been going on in the past 3 or 4 years. A bit of references for you in English on mentalizing. Recent, for those that are interested in PD, recent book by Bateman and Fonagy that came out. And pour ceux qui parlent en français, il y a aussi quelque chose en français. Eu não vou falar português, e meu português é muito ruim, então desculpe. J'ai seulement traduit en français. I only translate and wrote a book in French. So in preparing my talk, this was my objective, a clear view on where I want to go. Trying to present you some of the thoughts on psychosis. Unfortunately for you, this is what it gave. It's a very rocky start. I might fall off a ledge or drown, and then hopefully I'm going to make it up in the end under the gray skies towards a sunshine, happy ending, I hope. So I have really, just to introduce the talk, 2 key assumptions for you to keep in mind whilst I'm presenting. The first one is that from our point of view, psychotic expression is really on a continuum of non-clinical to more serious clinical manifestations, starting with slight dissociative or slight preclinical symptoms, towards more severe experiences of dissociation, towards sometimes withdrawal from reality. So this is for us important to keep in mind that we can learn a lot about people that have subclinical symptoms of psychosis, and we can also learn a lot about people with full-blown disorders, and we see this on a continuum. The second key assumption is that, of course, since we're dealing with often adolescents and young adults, we're taking a developmental perspective. And this means that we're interested in the different stages during development where the pathophysiology can actually gain ground and put the individual at higher risk of having a real disorder and of being kind of getting stuck in this disorder. So in the premorbid stage, we have, of course, the genetic and perinatal risk factors around conception and birth that play a role. The little blue drawings there are stress factors during childhood, environmental risk, early ND, which is early neurodevelopment, may play a role. And then during adolescence, other risk factors such as bullying, such as substance use, but also normal stressful factors in developmental tasks of intimate relationships, for example, can augment risk and then transition to adulthood. Now, the second step is, I don't know how much you are familiar with the concept of clinical high risk, but this is a step where a lot of research has shown that subclinical but serious symptoms often predict the transition to FEP, first episode psychosis. And so I'm going to spend a little bit of time on the concept of clinical high risk so that we're on the same page. But this is just to illustrate the developmental path, and for you to remember as well that people at risk don't all develop the disorder. And so every time you see the little red arrows, every time we're crossing a stage, there's only a small proportion of individuals that go from one stage to another. For example, with genetic risk, we know that 9% out of 10 with genetic risk for schizophrenia will not develop psychosis. So this is important to keep in mind. So we're both learning about resilience factors, why do they not develop, but also markers of transition to psychosis. Okay, so let me just spend a few minutes on the clinical high risk for those that are not familiar with the concept. This is really an assessment that looks at unusual thought content, delusional ideas, suspicion, persecutory ideas, grandiosity, perceptual abnormalities or hallucinations, and disorganized communication at a subclinical level, meaning that the individual can criticize these symptoms, but is still severely disturbed emotionally and perhaps functionally by these symptoms. Okay, so they don't meet the criteria for psychosis or brief psychotic episode, but they are present and they are reported by the individual. You might know these as prodromal symptoms, even though the term prodrome is not so much used anymore. So the important thing to remember here is that there's a set of states that may be predictive of a transition to a diagnosable disorder. Some people look at these symptoms, which are mainly positive symptoms, indeed, subclinical positive symptoms. Another recent approach has looked at what we call basic symptoms, which actually are subjectively reported sense of disturbance of oneself, one's control in attention, thought, or perceptual processes. So this is an interesting set of symptoms because they're not diagnosed by the clinician, they're diagnosed by the patient or by the individual himself, okay? And so they range from thought interference to unstable ideas of reference to derealization, and they need to occur at least weekly to be considered as basic symptoms. Any one of us might have had these symptoms once in a while, but perhaps not weekly. And once you get into a weekly frequency, then you're in a clinical high-risk state for converting to psychosis. Okay? So these are two different ways of analyzing whether, or of examining whether an individual is at higher risk of transitioning to psychosis, okay? What does it give when we follow up these individuals over 48 months? Well, you can see the cumulative conversion rate of psychotic disorders, which is already pretty high at the first 18 months. And then for both sets, the UHR, the first set of symptoms, which really talk about the positive symptoms, and the second set, the basic symptoms, they converge to around 30% of conversion to psychosis. Okay? So if a patient is in that state, he has basically 3 chances out of 10 to convert. Okay? What about a patient who would show both subclinical positive symptoms, which we call attenuated positive symptoms, and basic symptoms? What is the conversion rate? Right now, studies seem to show that actually it's 70%. So this is these are clinical interviews that can really warn us about, for some individuals, they are at very high risk to convert to psychosis. Okay? So the idea here is to catch the pathology as it is growing potentially into a clinical disorder. Okay? So back to our hypothesis here, our developmental perspective. We're at stage number 2, the clinical high risk, with both these sets of symptoms that might predict conversion. And what do we find in terms of global functioning of these people? Well, what we see is that on the green line, you see the symptoms going up and reaching their peak level at the first episode, okay? And then with proper medication and proper care, usually we have some success in reducing the symptoms themselves, especially the positive symptoms, to a lower level, as you can see with the green line. The big problem that we have is, as soon as these symptoms emerge, even in the clinical high risk, we have a functional impairment that sets in, especially in interpersonal relationships or in professional functioning, with which we have a very hard time to treat and get these individuals back into regular, stable lives, as their disability, their functional impairment stays high, even though we reduce the symptoms. Yeah? So this is called the symptom disability gap, and this is what we think is our main problem with psychosis right now, is that we're able to treat mostly positive symptoms, we're able to treat them, but actually the functional impairments, we have a real difficulty in getting patients to get better and back into fulfilling lives. Okay? So that's the background. And I'm going to give you the conclusion of the talk now, because I tend to speak slowly, as you can see, because I'm Swiss, so I speak slowly. But also to have it in our minds that actually I'm going to present to you some evidence that the social cognitive, the understanding of social world and the understanding of minds, and impairment in this understanding is already present in the premorbid stage and the clinical high-risk stage. And it's also, we see it quite impaired down the line, okay? And it's tempting to think that these social cognitive skills grow between the age of, for example, 16 and the age of 30, right? Think about how you were thinking about relationships when you were 16, and think about how you were thinking about relationships when you were 30. It's not the same thing. It's a completely different world. And it's this social cognitive specialization, okay, that goes on through complex social interaction, developmental tasks asking us to think about ourselves in the world, to find a place in the world, to increase our autonomy, to take responsibilities. This is quite a task, or quite a set of tasks that happen between 16 and 30, period in which, if you're in a clinical high risk or first episode, you are basically taken away from key experiential training, if you like, or just living and specializing in these skills. And basically what we're thinking is that this key developmental window might then correlate with the functional deficits that we see down the line in full-blown psychosis. Okay? The learning of mentalizing starts with attachment, starts within the attachment bond, leads to trust, and also leads to trust in, faith in social individuals or social knowledge, faith that I might learn something from other people, that I do not need to retract from society or to retreat, but rather I'm trusting that actually there are things to discover about myself in the minds of others. Okay? It's easily disrupted by significant arousal. We already talked about this. And it's central to PD phenomenology, personality disorder phenomenology. It's also, we think, impaired in psychotic disorders, but along the psychosis continuum indeed. And so mirroring, we talked a bit about mirroring, which is the kind of social biofeedback that parents engage in with their children when they're attuning to their emotion and they're communicating about emotions. And the three characteristics of mirroring that we find with children, we also kind of do an analogy with therapeutic work when we actually work with patients in trying to understand and emotionally communicate with patients. The first characteristic is contingency, meaning that when an emotion is expressed, we don't wait 10, 20 minutes to address it. We actually address it as it is expressed within the embodied actual experience of this emotion. And this helps learning because the individual, the baby here, can actually associate between what they feel inside and what the feedback is on the mother's face or on the father's face in gestures and tone, etc. This associative learning is quite important to get to know about identifying what is going on in oneself. The other one is congruency, meaning that the social biofeedback that we're giving is within the same emotional register as what is expressed by the individual, right? So if a child is crying, I'm not going to start laughing, okay? Or if I am, I will not effectively regulate the emotion, okay? And so going on multiple interactions, thousands of interactions during childhood and adolescence, this congruency helps the individual establish different registers of different emotional experiences: sadness, surprise, fear, the basic emotions, either in Ekman or we talked about a bit about Panksepp. This is differentiated through the feedback, the congruent feedback of the environment. And finally, the marking of the social biofeedback, namely the fact that when I engage in emotional talk with a baby, I will talk about the emotion and I will not necessarily react emotionally myself, helps the baby decouple the initial arousal of the emotion and its effects on the environment. Because you could give me an example saying, well, you know, if a mother sees a child cry and she cries immediately herself, well, that is congruent and that is contingent, right? It's in the same emotional register and the timing is on. But it's not marked, it's not decoupled, it's more of emotional contagion. See? And this emotional contagion phenomena blurs the internal world of the child, and also affects his or her capacity to regulate emotions. And so this, in analogy, a lot of the work that we do in therapy goes through providing feedback on what is communicated by the patient and trying to understand. Mirroring is not about getting it right. It's about keeping a stance to try to understand, keeping the process alive of trying to understand emotions, okay? When one is exposed to threat, the attachment system is activated through the distress-fear response that would call upon the activation of the system to seek proximity to the caregiver and to downregulate the emotions. The constant cycle of this interactional loop actually builds the bond, the attachment relationship, and also the trust that when I go to my caregiver, I can actually learn something useful about myself or something useful about what is going on, okay? The way we do research on mentalizing is by operationalizing it on 4 dimensions, okay? I just mentioned that sometimes when we're very aroused, we polarize our mentalizing. I'll give you a few examples. The first dimension is that we basically mentalize in a very automatic fashion. We also mentalize in a controlled fashion, but for example, when you come to a dinner party and you have to choose a seat where you're going to sit, you're going to look around the people and you're going to choose a seat. You're going to have an impression about people that is about who they are, and it's not very explicitly stated in your mind, but you are taking decisions upon this automatic mentalizing process. And as the night goes on, you might regret having sat there because you hear more interesting stuff about other people, and explicitly you think to yourself, well, this person over there is quite interesting. We have common goals or common interests, and so I might have done a bad decision. So the automatic is more non-conscious, parallel process, while the reflective is slower, serial process mentalizing. When we think about others and ourselves, we either think about psychological reality or psychic reality, which cannot be perceived by our eyes. We have to infer it. But also, we analyze what we see in people's bodies, gestures, the way they move their eyes, the way they react, and those are very externally perceivable cues. And so we use both of these informations, okay? Some adolescents, when they look at you and say, "What are you looking at?" They're really only sticking to the way that the external features, and they're not mentalizing on the basis of what could be in your mind, okay? So they're polarized sometimes in the external dimension. When we think about mental states, we often think about either beliefs, desires, or we think about affective content. I'm sure this has happened to you. You said to a patient, "Oh, so this is what happened. How did you feel?" And the patient answers, "Well, I thought that blah, 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 blah." Oh, okay, interesting. But tell me, how did you feel? So, "Well, then I thought again, and I thought that she thought that they thought." Okay. But how did you feel? So trying to get her to consider the affective polarity of mentalizing and bind that together to enrich the mental representation. Okay? And finally, of course, we can mentalize about self and others, and our own mentalizing can be either very influenced by our own thoughts, feelings, okay, the projective kind of mentalizing, or it can be differentiated from our own perspective, which is more on the other side, okay? And of course, these dimensions have been operationalized because we think that they match on to some of the systems that have been identified in affective neuroscience and developmental affective neuroscience. And so this is work in progress, and this is really a hypothesis at this stage. Okay? But actually, clinically, it's quite useful, because when you start listening to material, to mentalized material as being either polarized on one end or another dimensions, then this suggests to you as a therapist that you might want to help the person integrate the other side. And this is something you already do probably. This is just made a bit more explicit here in the mentalization framework. So good mentalizing is about binding, another concept that comes from psychoanalysis. And it's not about necessarily getting it right, but it's about fostering this process of binding and of considering the information coming from the different poles of mentalization. And so, if you will, it's a concept that is quite vague, because it is at the crossroads of different other concepts that have been perhaps more narrowly defined and more specifically defined, such as theory of mind, mindfulness, psychological mindedness, empathy, affective consciousness. But from our point of view, these concepts sometimes do not fully capture the breadth of mentalizing. If you take mindfulness, for example, mindfulness is not so much interested in automatic processes, much more explicit, slow, controlled processes. And mindfulness is not so much oriented towards other. It's quite oriented towards self, right? And of course, there are evolutions in mindfulness right now that seek to integrate these different polarities, but typically, this is the kind of differences that we find, although all of these concepts are much more easy to measure than mentalization itself, okay? So we are lagging behind in the measurement department for sure, okay? So let's come back to our concern, our main concern, which is psychosis. What is the evidence that actually brings me to say that we can see mentalizing problems, perhaps subtle in the early stages of psychosis, of the psychotic continuum, and more serious in the later stages? Well, if you take tests such as theory of mind, such as reality or self-monitoring, insight, or perspective taking, where you're going to find a host of studies that show that in premorbid schizotypy or psychotic-like experiences, that's PLEs, in individuals with genetic risk, in clinical high-risk states, first episode psychosis or schizophrenia, you're going to find a host of studies that report significant differences in these social cognitive competences that we pull under the rubric of mentalizing. And we've reviewed that in a paper recently. Another interesting set of studies shows that in children, 9 to 12-year-olds that report auditory verbal hallucinations, this is about 10% of the population. These children actually, in theory of mind task, over-attribute mental states. They use mental state talk in a hyper way. This is why Clemenson called it the hyper theory of mind. Others called it hypermentalizing. And it seems to go hand in hand with perhaps a polarization of mentalization and a vulnerability to experience early psychotic symptoms. Now, what happens with these psychotic symptoms in children is usually that they disappear by themselves, right? A lot of studies by Sandra Escher and Marius Rome in the Netherlands have shown that these experiences, in general, fade away without any real therapeutic treatment indeed. However, for a subset of individuals, they persist, okay? And in these individuals are at much higher risk of developing psychosis. Now, an interesting study showed that actually for those individuals that had good theory of mind skills, they were much less likely to develop delusional thinking following their early auditory verbal hallucinations. This is the Bartel-Vertus study. And another study, but this now in a sample of adults, called the voice hearers, meaning individuals who hear voices but who are not clinically diagnosable or clinically ill and who are leading quite typical lives, But they hear voices. There are voice hearer groups all around Europe. And this recent study showed that these individuals have one characteristic that differentiates themselves both from patients with voices and also from controls, is that they are better at mindfulness than controls even. They're superior at mindfulness than controls. And these are the kind of results that suggest that actually, while mentalizing might not be an etiological causal factor of psychosis, it might be a protective factor that prevents or attenuates the pathological valence of these early experiences and the transition towards clinical states. Okay, so this is the kind of hypothesis that we're exploring. Now, in psychotic disorders, it's a recent meta-analysis and a review paper that shows that the reflexive emotion experience, motor resonance, and affect sharing are either intact or, the results are a bit equivocal in terms of whether there's a real impairment or not. And the impairment is much more clear on the reflective side, the thinking that goes on in imagining what is in one's mind and in others' mind, that seems to be really impaired. Okay, mentalizing is part of that. Okay, so a few words on trauma here, because there have been quite a few studies along the years that have identified that people with psychosis often suffered trauma. And this, of course, has an impact for our framework, because if there is trauma in the early attachment relationships, then the kind of social feedback loop that is trying to set itself up and sustain mentalizing well might be burdened by trauma. Okay, so a few reviews that we did here. Very high rates of trauma in samples of individuals with schizophrenia, and even in samples of individuals with clinical high risk. So this is the 30% that might convert to psychosis. Okay, and a lot of studies have been criticized because of a retrospective bias, saying, well, these guys, maybe they're not remembering correctly, or maybe there's an effect of what they've endured recently on their reporting, but actually their reporting seems to be quite concurrently valid with parental bonding measures as well as with clinical case notes when they were available as children, when they consulted as children. Okay? Prospective studies show that actually in children who have auditory verbal hallucinations, those that experience trauma as well would have phenomena that tended to last more during adolescence. Okay, more persistence and more severity when traumatic and stress-inducing events were associated. And also, the exposure to these traumas were highly predictive of the later development of further psychotic experiences over time. Okay? In first episode psychosis, so now we're at step 3 of our developmental model, insecure attachment has been correlated, has been found in first episode samples, and attachment avoidance as well, quite prevalent, and quite then implicated in the difficulty of these patients to trust others and to seek treatment in a regular fashion. And finally, the same for psychotic disorders, where actually attachment security here is one of the protective factors, because it favors the kinds of psychosocial treatments that we're offering them. Okay? So here, if we slightly modify our circular model of exposure to threat leading to the activation of the attachment system, in a situation where the attachment figures are dangerous, well then the distress and activation of the attachment systems leading to proximity seeking will be met with another additional adverse experience, which may lead the individuals to either develop a disorganized, kind of ambivalent sense and fearful sense of what should I do or how should I deal with these adverse experiences, but also in some other individuals quite clearly suppress attachment needs as something that needs to be put on the side because actually it's dangerous to seek some of these attachment figures sometimes, okay? So very quickly on the neurobiology of psychosis. I'm not going to be long on this because I know it's Saturday afternoon and that you've had a lot of brain talk. So I'll try to be as brief as possible. But basically, this is work by Benjamin Brent, our colleague in Boston, starting from the attachment disturbance hypothesis. What we can see in childhood is that what the kind of system that is going to be affected obviously is the stress regulation system, the HPA axis, right? But also there is some evidence that the attachment oxytonergic system interacts with the other systems, notably the dopamine dysregulation system, to perhaps foster increased states of awareness during adolescence. This is the salience hypothesis of schizophrenia, meaning that there's aberrant salience of sometimes unimportant details that might stem from these heightened states of awareness, and with mentalizing impairments in the early relationship, promoting potentially abnormal abnormal experiences of social explanations, then the whole social cognitive process during adolescence might be at risk here. And all of these contribute to the building up of potentially delusional explanations of self in the social world, and through recurring interpersonal stress may then lead to a crisis or a psychotic episode, for example. Okay, this is a developmental model. It's also a model that links the social cognitive mechanisms to the neurobiological mechanisms. And finally, it's a model that posits that there are intervening stressors here that all along the line perhaps we can work with or intervene with to reduce the risk. Okay. Very quickly, a brain slide here. We heard in the last talk that during adolescence there is quite normal pruning of the cerebral cortex, right? And this is a basic biological fact that happens to every one of us, and that works towards a specialization of our brain networks, yeah? What seems to be going on in the clinically high-risk individuals that end up converting to psychosis is that part of this pruning, especially in the frontal cortex, seems to be more rapid and disorganized, okay? Especially in the region here on the right, the region that is yellow and red. This is a comparison between converters and non-converters, all of them being at risk. And for those that convert, there's something in this part of the cortex that seemed to go wrong during maturation, and we don't understand it quite well. But what we know about this region, and Chris Frith and colleagues have identified that quite early, is that it's a key region for mind reading, okay? So, indeed, not only are these adolescents and young adults facing external stressors, but there's something in their maturation, their brain maturation, that poses another obstacle to consolidating and specializing mentalization skills. Okay? But of course, this is not the only pathway. There are a variety of different pathways that neurobiology, that have been identified in neurobiology. And For us working more clinically, what's important to remember is that with a genetic predisposition, attachment problems and potentially stressful events or trauma, these work together to influence a variety of different levels in the body, in the brain, whether it's neuroinflammation, whether it's the HPA axis, whether it's dopamine dysregulation, reduced oxytocin, or oxidative stress damage. For those of you who want to know more about it, we've reviewed it briefly. But what we're arguing is that all of these actually also contribute to the processing of embodied sensory experience, as well as to cognitive impairments such as the biases, or if you like, the more projective mechanisms that seem to be rigid quite early in these individuals. Okay? And so a variety of pathways neurobiologically are also pushing the risk upwards. Okay? So to finish with a clinical vignette, the story here is that in thinking about how to intervene in the clinical high-risk stage, well, we first ask clinicians what, the types of most important distress were reported by their patients, by these CHR patients. The top three distress symptoms were social and functional difficulties, depressive symptoms, and attenuated psychotic symptoms. Okay? So this means that we would not employ a modular therapy focusing on early hallucinations, for example, because this might not respond to the clinical needs of these individuals. Okay? And the clinical needs are not only around psychotic phenomenology, but they're also around depressive and social functional difficulties. So we need a method that can address all of these. Okay? Second of all, the symptoms that predict conversion are not necessarily the same that the person is struggling with, or that the person says he's struggling with most. So for example, APS, which is attenuated psychotic symptoms, anxiety, and substance abuse are the symptoms that also predict conversion. So we need to keep that in mind. Whilst we're responding to the demand, we also have to keep in mind that substance use, for example, needs to be a key target for our method, because this is what seems to be also promoting conversion to more serious psychopathology. Okay? Give you the basic therapeutic stance in MBT, and this is not dissimilar from the therapeutic stance with borderline personality disorder, is that we aim to direct attention on the present moment. What is the rationale for really trying to direct our attention really on the present moment, on the here and now? Well, the rationale is that we are very aware that arousal can be quite labile, and also that the more arousal there is, the less mentalization there is, the less thinking processes there can be. And so we want to reduce any kind of cognitive complexity or cognitive charge of asking far distant memories or asking complex representational or symbolic questions, because that actually is more difficult to deal with for individuals with either intense arousal, emotional dysregulation difficulties, or even in the psychosis range, individuals which have ruptures in their sense of continuity of self. Okay? And so we want to direct as much as we can attention on the present moment, and we want to create a process of joint attention where we're both looking at the mental quality or the mental dimension of experience, okay? And how that mental dimension actually influences embodied experience, affectivity, and also interpersonal relationships. And when possible, when we notice that actually these patients quite adequately mentalize each other, or mental lives themselves, then we want to underline that to reinforce the fact that they're able to do it and that it makes a difference in the way that they can enjoy life, learn, and get on with their relations. Okay, so I'll give you an example that is published here, an example by my colleague Benjamin Brent of a young female he treated, 25 years old, with 4 brothers and sisters. She was hospitalized once for paranoid delusions with auditory verbal hallucinations. She says she is seeking help for depression caused by professional failure and her incapacity to develop stable, intimate relationships. So as I mentioned before, not necessarily seek help for their psychotic symptoms directly. And this is where we start with them. She reports being incapable to feel close to people, and we know that also she has divorced parents and she has lived with her grandmother starting age 10. So we know about that in her history, from a developmental perspective, she has had severe attachment ruptures. During adolescence, she developed a fantasy that she might be a fallen angel and wondered whether God was communicating clues to her being a fallen angel. So this is one example of a clinical high-risk symptom before the onset of a disorder. Once she got to university, well, she had very few friends, as she had very few friends previously in school. She failed her first classes at university, and she started worrying of becoming a failure. And indeed, concomitantly, she developed the conviction that this failing was God's way of punishing her. Okay, and this led to more and more construction of a delusional content that got her to be hospitalized for first episode psychosis, treated with neuroleptics with the stabilization of symptoms, but with severely impaired social functioning. Okay, so this might also resonate with some of your patients in your practice. Her quasi-psychotic and psychotic episodes were linked to attachment system stressors, for example, the divorce of the parents, or her leaving the house for the studies, this interruption in attachment continuity. And her mentalizing capacity is particularly impaired in situations of social stress, which can activate attachment needs. For example, during university parties, she would not speak to anyone because she was convinced that everyone thought she was a failure. She said, "Everyone here has done something with their life, not me. They all think that I'm a total loser," which is not an irregular thought in a university student, but for her really impeded any kind of social interaction. So here we say that she's mentalizing in psychic equivalence, meaning that she is convinced that what she believes is also the beliefs in the minds of others, and that this influences the way how she relates to other people quite seriously. So I'll give you a very short vignette here where Rochelle mentions during the few sessions that she sometimes is feeling that somebody is tape recording the session. Okay? It is a short-lived thought, it's a very quick thought, but it bothers her quite a bit. Okay? And so that might actually impede the communication with the therapist if she's thinking that somebody's recording her. Okay? And so the therapist says, "Well, can you tell me a bit more about these thoughts? When did you first notice having them?" Okay, and so typically in an MBT stance, the therapist is quite active, although quite sensitive to not be intrusive. Rochelle answers, "Well, during the last hour, actually, I remember just looking at how the walls in your office are undecorated, just plain white walls. I started thinking, is this a real doctor's office? And then I wondered whether you might be recording me." Okay? It's a good example of concrete mentalizing, meaning mentalizing on the basis of very concrete physical cues. Nothing on the wall, this is plain, is this real? And you see the disruption in self-continuity here as she is experiencing this awkward relatedness to the therapist. Therapist said, "Well, I'm not sure I understand how you go from noticing that the white walls there were white walls in my office were connected to the thought that I was recording you. How can you kind of tell me how you get from the concrete observation to how you're thinking about what I'm doing here? Did you have any particular feelings? Okay, focus on feelings, focus on affect when you were looking at the walls. Pause. When I look at the walls, it feels like you're not really there, or you're not really here, like you could be planning to leave any minute. Okay, so there's attachment representations here that are emerging as the therapist focuses on affect. The therapist says, well, so perhaps when you feel that someone is going to leave you, you can start to worry about being hurt, like the idea that I'd record you without your permission. Okay? So here, trying to qualify and label the affect and trying to link her experience with the kind of concrete mentalizing that she was going on. Yeah, well, I think that's right. She said, well, how has it felt to talk about this just now? Okay? What is going on with your feelings as we are talking about it now? So this is the focus on the present moment. Okay? And so, well, it's been okay, actually. I kind of feel more connected to you today. Okay? So this is the kind of experience that we're trying to generate, and we're trying to underscore the fact that they can have these disconnected, of course, experiences we can talk about, but also when we get to talk about mental states underlying these or potentially connected with these, because we're never sure that they are, then actually that has an emotion regulation effect, and indeed an interpersonal, intersubjective effect. Okay? So the intervention principles is to be simple, to be adjusted to the level of mentalization, to be careful not to put in too much mental state talk, to be centered on affect and on the patient's mind and not their behavior, to focus on correct events and facts, to work in working memory, as we say, to target the pre-conscious and conscious content rather than the unconscious conflict. And this we do so not because we don't believe that there is unconscious conflict. Of course, there is unconscious conflict, but actually, we actually might perturb the process of building mentalization within the relationship if we go far off into the unconscious conflict. Okay, and of course, we include family and group work. I won't have time to go into this. So actually, we're treating the psychotic manifestations here as moments of disturbance in core self. And of course, this is not a new idea. A host of psychoanalysts have talked about it, whether it's Klein, whether it's Bion, Winnicott, Daniel Stern, or even Sidney Blatt and colleagues, all talked about how there's the schizophrenic hyperreflexivity, for example, in Blatt, may follow from a failure to establish or find a bodily sense of self, a continuous sense of self that, of course, as babies, we nurtured through the accurate and stable social biofeedback of mirroring, but also holding, handling of the baby's body onto childhood and adolescence, and how the environment has really helped us build this continuity, this illusion of a continuous self, which is a very useful illusion that we have. And when we don't have it, actually, these experiences of disturbance in core self may severely impair relatedness and also interpretation of others' behaviors in psychotic ways. And so the loss of mentalizing following this core self-disturbance will create impaired mentalizing, potentially the loss of capacity to actually consider alternative evidence, contrary evidence to one's thought, increased rigidity here, and where more and more others become incomprehensible to oneself. And it becomes very tempting to retreat then in our own subjective viewpoints. This happens to us quite regularly, for example, when we get angry with our boss. Okay, we will retreat in our own explanations of his psychodynamic or her psychodynamic problems. Okay, and we will sometimes even retract from the relationship. But this does not affect our all functioning, hopefully. Okay, in these situations, there's something quite total about the retreat and the distrust in people's minds generally, which then, of course, is also invested through uncertainty about the reality of symbolic verbal content, perhaps bizarre speech and behavior, which entertain further disturbances in core self. Okay, so the idea here is that very basically what we'll try to do is identify triggers, either in the social evaluation or social environment, the interpersonal relationships, either in affective arousal or perhaps in hyper-reflectivity that also tends to create discontinuities of the self. And then if we identify the triggers, then we also try individually with each person to characterize the type of impairments that they may have in mentalizing. We perhaps will try to offer non-threatening alternative perspectives when that is possible. We will specifically, and this is even more important in psychosis than BPD, to make our own thought process explicit, meaning why did I think how I thought? How did I get to think this? Okay, we will be very simple and explicit in trying to provide a social biofeedback to how we're thinking about the individual. We will try to contain retreatment behavior with a secure environment, and here, of course, we think about therapeutic communities, or we think about different multi-level interventions that include the family, the school, to provide as wide a secure environment and on the most levels as possible. We avoid complicated mental state or hypersymbolic thought, and we provide non-threatening feedback to what we actually consider as being bizarre or actually consider as behavior that might trigger reactions in peers or reactions in other people. We're quite explicit about, but non-threatening about thinking how these bizarre behaviors actually disserve the purpose of the individual. Okay? And so to conclude, as I said in the beginning, there's quite a bit of evidence showing early impairments in social cognition. Therefore, we think that might represent a target, a key target for treatment. And we need some longitudinal studies on this. Prevention also needs to specifically support the social cognitive learning through adolescence and early adulthood. And perhaps that indeed we treat loss of mentalizing as following from a loss of sense of self. And what we're going to try with the different activities, not only psychotherapeutic, but also in the different ateliers that you might have in a community setting or in a multimodal setting, we are going to try to target the embodied mentalizing that might be fostered in these different activities as the key to rekindling a mentalization capacity in these individuals. Okay? All right, so muito obrigado, and thank you for your attention. If you would like the slides, just write me an email.